We're hearing a lot about addictions to many things, from drugs to habits. What can we do about it? Tonight, On Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. We're hearing a lot about addiction to prescription drugs, alcohol, gambling, many other things. There's even a question as to whether or not opioids are any better at pain control than Tylenol. First, let's take a look at this week's Prairie Doc quiz question. How many people died in the U.S. in 2017 of car crashes? How many died of alcohol abuse? How many died from suffocation from opioids? We'll have the answers at the end of our show. Joining us tonight is Dr. Bob Vandemark, President of South Dakota State Medical Association, and Dr. Matt Stanley with the Avera Behavioral Health. Gentlemen, thank you for joining us.
Thank you.
Thanks, Rick.
I love this. We have an orthopedic surgeon, a psychiatrist, and an internist. It's almost, they walked into a bar.
Yeah.
I can just feel it. But it's a nice diversity of experts around the table tonight. I just love it. It's going to be interesting to see where it goes. But we're talking about addiction. And I thought maybe we would start with you, Matt. What is your official job, by the way? What is your title?
My title is, along with being a psychiatrist, I'm the vice president for the behavioral health service line. So that's just a way within Avera that we've aligned our different specialties and different care delivery models.
And the behavioral health hospital is a kind of a special place. How is it in comparison to the hospitals across the country?
Well, I would tell you that we've been told by the president of the Association of Psychiatric Hospitals that it's the finest facility west of the Mississippi. So we're fortunate, I think, in that we have 122 beds, we have a residency, a psychopharmacology residency, on and on. I would just tell you it's a very enriched environment with a very modern and, I think, progressive feel, which reflects our belief that, whether it's mental health as much as orthopedic problems or cardiovascular, behavioral health issues deserve the same dignity and respect as any other form of medical disease.
Right. And let's talk to another form of medical disease, orthopedic surgery. I mean, your dad was my teacher and a venerated, wonderful man, a first orthopedist in the state of South Dakota, and well-known, Bob. I mean, you've heard that a million times.
Yeah.
I mean, he was quite a guy. Tell me a little bit about your dad.
He grew up in Alexandria, South Dakota, wanted to be a farmer, and ended up going to medical school, first at USD and then transferred to Northwestern.
Back in those days, we had to do that.
Yeah, and did the residency at the Mayo Clinic, was in the Army for 3 years, and came back to Sioux Falls in 1945.
The first official orthopedic.
Well, in fact, he joined his uncle, who had been practicing orthopedics since 1907, before it was officially orthopedics.
Yeah, that's an interesting thing. And then you followed him.
I did.
Yes, you did. And you were in the class behind me in med school. I mean, you transferred too. Where did you transfer?
To Tufts University in Boston.
How was that experience?
Good.
Did you do your fellowship there? Or,
no, I came back and did my internship at McKinnon, now Avera. And then I spent 4 years at the Mayo Clinic in Rochester, Minnesota, doing orthopedics. And we went to LA for a year for a hand fellowship.
So you're a hand specialist?
Yes.
And now there's the Vandemark Sanford Orthopedic Institute.
Well, there's a building, yes.
There it is.
Yeah.
And you're part of that, and we are pleased to have you here.
Thank you.
But as the State Medical Association president, tell us about what your whole thing has been with the State Medical Association.
Well, last year the association received an educational grant from the Department of Health from the state to develop an educational program for both providers,
the physicians and the nurse practitioners, PAs.
The levels, and for the patients.
Patients as well.
Yes, we now have that up on our website for both providers and patients to talk about prescribing addiction services and to try to educate people on the danger of opioids.
And we want to talk about opioids, and I want to get into that just as deep as we can. But I want to go back to addiction in general and talk about what Avera's doing with addiction right now, Matt.
Well, I think along with Bob and Sanford and all the systems in the state, we've been challenged both by the idea there's a national crisis, and then, as Bob said, with the STSMA.
State Medical Association.
At the state level, we really didn't have a plan to address this crisis a few years ago. So, and the STSMA, took a progressive stance. I think we wanted to police ourselves. Bob, I was fortunate enough to work with Bob on that committee, and I think it's fair to say, though, that this kind of blindsided us all, and is probably why the numbers have become so tremendously large. So Avera, like other health systems, has both worked with STSMA, both worked with federal guidelines, but we've tried to internally create our own approach, and it incorporates a lot of what Dr. Vandemark was just talking about. It has to include patient education, and that should always be a part of good medical treatment. That's informed consent, but I think there are a lot of factors created an unrealistic expectation in patients, which we now have to reframe. We don't like to be in conflict with our patients. We're compassionate people. We got into this to help, and nobody likes conflict to begin with. So I think that's a big component of how we turn this thing around.
Right. Well, who's to blame for this 65,000 people death a year?
That is a fantastic question, and it probably depends on who you ask.
Yeah. And I want to get into that, but I also want to talk about addictions in general and the hospital that you're planning on.
That we're creating?
Yes.
Yeah, so one of the things, as I said, we have a 122-bed psychiatric facility already. One of the things you'll note when you look at addictions is that, depending on which research you look at, it's 60 to 80% of people with an addiction also have what we call co-occurring disorder, a psychiatric disorder, depression, anxiety, panic. 60 to 80%. So in other words, the vast majority, exactly. Regardless, the old kind of approach was you need to treat consecutively. In other words, you get sober for 6 months or a year, and then we'll work on your depression. The new model is you have to treat concurrently, which makes a lot more sense to me, but is harder in that you are working with the brain environment, and a lot of what we do in psychiatry now is try to readjust the neurochemical mix there, but you're not working on a clean slate.
No.
So there's challenges.
60 to 80% have other concurrent psychiatric issues along with this addiction problem.
And so what we see in behavioral health, we see a large number of patients that come in for depression, anxiety, et cetera, but they also have an addiction issue, or at least an abuse issue. And that's another discussion, difference between abuse and addiction. We needed more facilities with hopefully better approaches to care. We believe and hope and believe that we will provide a higher quality with a higher response rate in our treatment.
So they're building a building in Sioux Falls that is going to be just for addiction.
Correct.
But it's not just opioid addiction. Opioid meaning narcotic, all of the narcotics. But it's not just opioid addiction. It's any addiction, correct?
Yeah, so opioids is stealing the headline, but it doesn't mean that alcohol has become any less of an issue in this. Or, in this region, as I said, meth actually would probably be, if you looked at problematic drugs in this region, and law enforcement might say a little bit of both, but there's a panoply of drugs that are frequently abused, and people become dependent on, addicted to.
So, what are the numbers, Bob, about the national dangers that's going on with narcotics?
I think in 2016, I think there were 64 or 65,000 people who died. Number one drug was fentanyl, which is illegal, and number two is heroin, which is illegal, and number three is the opioids.
All the rest of the prescription opioid.
And they're predicting by 2025 there'll be 20,000 opioid-related deaths, prescription drugs, and 72,000 non-prescription deaths.
Wow. So
from fentanyl.
So they're predicting the numbers are just going to keep on going.
Right.
We're going to be writing less prescriptions.
Yes.
But they're going to go with the fentanyl and the new elephant fentanyl-like.
The carfentanil.
Carfentanil. yes.
Explain that. What is that?
It's a drug used to tranquilize elephants. And I think it's, was it 10,000 times
Up to 10,000 times stronger.
The morphine.
Yeah. So
So-
strong, in fact, it was actually contemplated, and we had concerns that it could become weaponized.
Yeah.
So you could disperse that powerful opioid in the air, and it would just touch you or be inhaled or whatever,
And then you
people
die.
would go down.
I think
Stop breathing.
2 grains of salt size would kill you.
Wow. So we're predicting that that's going to keep happening.
Yes.
Now, I've heard, though, that 4 out of 5 heroin users started from prescription pain medicine.
Yes, that's true.
What do you think that's all
It's
about?
cheaper to buy heroin than to buy opioids on the
So
street,
so they got started with the narcotics
Right.
from the prescription of the pen of the care provider.
or somewhere.
Yeah.
Yeah.
So it's interesting, and you look at research a decade ago, those were really 2 distinct populations. We had people that would abuse opioids, we had people that would abuse heroin. And over the course of the last decade, that has blurred. They just use whatever they can get a hold of. So whether it's diverted prescription drugs off the street or whether it's heroin, as Bob said, heroin's actually, oddly enough, more easily accessible and cheaper in most cases. And here is where the carfentanil becomes dangerous. It's cheap enough and can be purchased. It's used to cut the drug or mix with the drug, and unbeknownst to the user,
It's a huge dose.
they've had a tremendous dose. It looks the same. It looks, and before we leave the topic of carfentanil, when we talk to law enforcement about this, they're aware of the risks of carfentanil and how potent this is. They now have to wear PPE, the personal protective,
Hazmat suits.
when they make a bust.
Yeah.
Because it is
that powerful.
deadly dangerous.
Yeah.
You remember when meth labs kind of got, and
Yeah.
at first we didn't realize you can walk into one of those and it's dangerous. But
Yeah.
now there's a protocol. You have to go in with protective
Yeah.
equipment.
Important.
Yeah.
You were going to say something.
I think the unintended consequence now of making opioids harder to get is now it's easier to get heroin.
Yeah. Well, you talked about earlier about heroin in Sioux Falls.
I had a patient that wanted some pain pills and he didn't really need them. So we're trying to cut back on the number of prescriptions. And I said, you can buy a 30 milligram Oxycontin for $30, and black tar heroin for a gram is $60. And he looked at me and he said, it's $45. Sioux Falls. So I excused myself. Pardon me. That's a true story.
There's a new article out in the Journal of the American Medical Association about chronic pain of back, knee, hip, and the use of narcotics versus Tylenol.
Right.
What tell us about
Yeah, the story, from the Minneapolis VA, and they had 2 patient groups. And the one group was opioids, and they had give up to 100 morphine milligram equivalents, a big dose of opioids, versus the non-opioid group with Motrin, Tylenol, Aspercreme, acupuncture. And at 12 months, the non-opioid group had better pain scores than the opioid group, which is surprising.
Surprising.
Yeah.
I mean, people think that the opioid relieves pain better.
Right.
And it
Not so much.
Not so much. I think there's something about morphine or narcotics and obstruction of a smooth muscle tube. A biliary tract obstruction, a large intestinal obstruction, it stops the peristalsis and it gives some relief in that. But musculoskeletal, not so much.
No.
If you do develop a problem with addiction, South Dakota has a long and successful history of treatment.
A group of Sioux Falls businessmen formed a group called the Community Committee on Alcoholism and Drug Abuse and decided we needed a treatment center in the Sioux Falls area and found this area, which used to be originally Augustana College and then Augustana Academy. And they brought in Lynn Carroll, who started Hazelden, which was one of the first treatment centers in our country, to be the program director, and that happened 41 years ago. We run about 90 patients. We have 122 beds. Sometimes we're full, but we run between 90 and 100 patients usually.
We know that a person's substance abuse problem isn't going to be cured in 30 days, 45 days, or even up to 90 days, that it's a day-to-day process. And a lot of research is suggesting that as a CD counselor, as a chemical dependency counselor, we're advocating for up to 5 years of care. We also address mental health concerns, and that there's a number of mental health concerns. We are level 3.7 level of care at Keystone, so we do have access to nurses, we have access to psychiatry, we have access to medical doctors. So there is a psychopharmacology avenue that we can also refer our patient to the psychiatrist that may be having a concern that could be aided through psychopharmacology.
A majority of our kids do have some sort of co-occurring mental health condition too. Anxiety and depression are the biggest. Everybody is different. Sometimes when they have that epiphany moment and they say, yes, I have a problem, it's easy for them to slip back into that familiar, I don't have a problem. So it kind of moves back and forth between that. It's 2 steps forwards, 1 step back. As long as they're making constant progress, we always want to see them moving forward. But it's not uncommon for kids to test the limits and see if they can use again, and see whether all these treatment counselors know what they're talking about. We see kids come back sometimes 2-3 times, and they pick up something different each time that will help them in their recovery. Regardless of how they got here, they can still have that light bulb moment where they realize, you know what, maybe they got something there. Maybe there is a problem I need to look at. Oftentimes it's not the way we think it's going to be. We can't go out and say, yep, there's a problem with drugs and alcohol. They've got to start looking at it. Yes, I have a problem with my probation officer, and this is what I need to do to correct that, where substance use is a part of that problem.
I particularly like when the light bulbs go off, that it's not necessarily connected to something I've said or done. Another thing that's real beneficial at Keystone is we really work on the therapeutic community, so it's not necessarily contingent or that the progress in the patient only hinges on their work with their primary counselor or one of the doctors, that there's a microcosm of what their recovery program could look like after they leave Keystone.
There needs to be a power higher than Jack Daniels, and that's part of getting well, is discovering that.
What's interesting, this is a recorded show that we'll be playing later, and if you're watching it, you're going to be seeing it on TV, sometime in May, I think. Except it is live on Facebook. We are on live on Facebook on Thursday nights. And so we are getting questions from people on the Facebook feed. One of them had to do with, one of the Facebook viewers said, how do you distinguish legitimate pain patient needs versus someone who's addicted? And it reminds me, and I'll tell this story of being an intern at the VA hospital at Atlanta, Georgia. And the patient came in screaming bloody murder, wanting to have pain relief, and crying and pleading. And I'm caught with the dilemma of, is that person ploying me to try to get drugs? Is he an addict? Or is it really pain, real pain? And my conclusion at the time as an intern was, even if there were 5 addicts and this was one real person, who cares about the 5 addicts? I'm going to at least give that one guy some relief. And so I gave him the pain shot. And I think a lot of people in the emergency rooms are stuck with that dilemma.
Absolutely.
How do you answer that?
Well, and I think there is no good answer, and I think that's one of the reasons, and another component of why we've gotten to this place with pain. Pain is it's a symptom. And even if I look for cause, if I don't find it, that doesn't rule out that there is pain. The other thing is we all have different feelings of pain, ways to express it, and other things set us up. You mentioned before the break that Dr. Vandemark talked about the study and the fact that really other non-opioid were just as effective. In fact, there is no study that ever has said that opioids are good for long-term pain. They don't go, beyond. And physiologically, opioids are a drug that creates. You become adapted to it.
Yeah,
you need more
tachyphylaxis.
and more and more to get the same response.
Yeah.
Which in turn has other, the body is always trying to create stasis. And one of the reasons people may actually do worse after a year on opioids than they do on other is you get rebound pain. you become more sensitized to pain because your body used to be bathed in opioids.
And, you know, but you can also get rebound pain from, my migraine headache specialist told me that Tylenol gives a rebound pain as well, as do the nonsteroidals, although not as bad as Tylenol. Isn't that interesting? It's just hard to say that there is a good drug for pain.
Well, let's go back to the ethical dilemma you put us in with
Well,
your
okay.
intern story.
Bob, your response. What did you think about that pain relief of that guy screaming in the emergency?
Yeah, that's the problem. And now we now have a thing called the Prescription Drug Monitoring Program. So you can go online to see if someone's a frequent flyer. And so I guess in that situation, if I don't see the patient's name on the PDMP or the monitoring program, I'd be tempted. But like Matt was saying too, that's kind of what you do because people need some help and you really sometimes can't tell.
Your heart goes out to them.
Yeah.
And you're the only arbiter. I mean, you're judge and jury in that case. And, you know, I hate to see somebody with legitimate pain walk away. And it's a personal choice. I'd probably make the choice. I'd rather be benevolent than turn away somebody that's truly in excruciating pain because they have nowhere else to go.
Right.
Yeah, we've all done that.
Yeah,
I think.
of course we have. And then the other part of it is, you know, whether they're in having pain that's going to be helped by the narcotic, they are in trouble. Their heart is in pain. Their life is in pain. The narcotic is likely not the best answer, but there is no good answer for these people sometimes. So there it is. There was another question about Tylenol versus Motrin. Somebody asked, what about Motrin? Was Motrin in that study?
Yes.
And explain the nonsteroidals, Bob. What are the nonsteroidal anti-inflammatories?
They're like Motrin, Aleve, and they're basically an anti-inflammatory.
Yeah, like aspirin. I mean, aspirin is the granddaddy of all of those.
Yeah, and they're basically fairly safe except for some of the GI problems. I think Tylenol has a risk of having some damage if you take a large dose of Tylenol.
With whether the liver and chronically with the kidney.
Right.
So I had a nephrologist on the show one time, and I said, "Well, what about using Motrin and Advil?" And no, can't do it. Destroys the kidney. Well, what about Tylenol? Bad for the kidney.
It's all about perspective, right?
What can we do for some people? Well, there are non-steroidal, there are non-medicinal, non-medical, non-pharmaceutical ways. I'd like to talk a little bit about how we got into this. And if 4 out of 5 heroin addicts started because I gave them pain medicines, opioids, it really was from the prescribing hand of the physicians, the nurse practitioners, the PAs, the dentists.
I think you're mostly right, but let me challenge you on this. So the statistic says that 4 out of 5 heroin users started with abusing opioids. I don't think that means it all came from a physician prescribing it. I think that people, just like people use marijuana and it's been called a gateway drug, years later they're on multiple drugs. I think you see teenagers, you see adults, it's a prescription drug. It's probably safe. I'm going to take it. I like the sensation. There's a ton of drugs that are diverted, and that's where a lot of them. Yep. So
Meaning?
Legitimately prescribed or
to grandma.
Yeah, and in fact, if you look on the NIDA website and others, it will say the most common place that people get opioids is from a friend or family member.
Ooh.
So most of it is exactly what you said.
Diverted.
Gee, I'm at grandma's house. Let me check what's in the medicine cabinet.
Yeah.
Or I'm at a party and everybody's in there. I'm going to go see what they got in the closet here. So I don't want to make a miscorrelation that those 4 out of 5 heroin users all got started by a prescription. They all got started by an opioid. Many were probably prescriptions, but not all.
But I want to accept the blame. The physicians of
Fair
the
enough.
world
Fair enough.
have a responsibility here. But what you were going to say?
Well, I think, and for surgery, we've gotten to the point now that we have several studies showing that the majority of pills that we prescribe aren't used. And so, like one study was 92% of the pills the patient received were never used.
Yeah.
And so, of course, people don't know how to dispose of the medication properly, number one, and so they just kind of keep it around. So we're trying, as surgeons, I think, trying to make an effort to cut back. And now with electronic prescribing, you'll be able to do that. As opposed to the old days, you'd have to have a prescription in hand to go to the drugstore. Now that can be done electronically.
Right. So the question I have, though, is you're saying that that number should be a lot smaller when the physicians are prescribing, like 5 days worth of pain medicine?
They say 5 to stay alive. They've shown that anything more than 5 days increases your chance of dependency. It's like 6% of people go on to long-term opioid use. 3 months, it's like 15 times greater chance of becoming addicted.
Yeah. I had a Whipple procedure, and I have to be honest with you, I was on opioids, and I was dependent on it in 2 months, 2.5 months. I couldn't roll over in bed. And, but I think after a while, part of the pain was the fact that I was withdrawing from the
You'd been used
Sure.
to it, yeah.
Yeah.
So it's a monkey on your back. There's no question about it. I found myself in that dilemma.
But did you have a difficult time? So physically you were feeling it when you went down. Did you ever at a point feel like, I really want to stay on this? Or were you pretty clear?
Oh yeah, I could see where I was going, ooh, I don't want to take this, but I don't want to feel bad.
Right.
And I think, my heart goes out to people who are addicted. I mean, I can understand it. And some of them, they don't see that they've studied people who are addicts, many of whom are not. It's not a moral issue. They're good people. Some of them are functioning.
Yeah, and that's one thing. It's a misperception about addiction. Addiction, if you look at it in terms of what it does to the body and physiologically, alcohol addiction, I consider that a medical disorder. And I think you can say the same about opioids. Now that doesn't include everyone with an addiction hasn't or isn't willing to commit some morally wrong issues.
Right.
But an addiction itself doesn't mean that you somehow have a weak character or an ethical problem.
Yeah.
And then I do want to distinguish, there's a difference between physiological dependence, which you were just describing.
Right.
As this drug wears off, I feel horrible. I start to get sweaty, my heart races, I got nausea. That could happen with many drugs because your body's physiology that does not necessarily correlate to addiction. Addiction is when you keep taking the drug even though you know it's harmful for you, or you use unscrupulous means to obtain more. So there's a psychological, a thoughtful process that has to compound with that physiological dependence, and that's how we begin to define addiction.
Let's go outside of the opioid addiction story. I mean, there are other addictions. Of course, tobacco is a big addiction. Alcohol is an addiction. Methamphetamine is a big addiction. But there are also non-medicinal addictions like, stealing or gambling.
Told you I was going to challenge you on this.
Okay,
so stealing, so there is
Kleptomania, right?
kleptomania. There's a difference though between a
Shoplifting.
compulsion and an addiction. And let's go back to, we talked about physiological dependence and what that feels like. Dependence or addiction in our current parlance would mean that there's a physical component.
Yes.
That does not occur in kleptomania. Now you might feel like I get this tension when I'm in a store and I get kind of itchy, and when I grab something I get this relief, and that's a different process.
Gambling. People can't stop.
Gambling does have, it has interesting neurochemical responses, and even the type of gambling lights up some of the neurotransmitters more than others. So
People can't stop.
Poorly understood, a growing problem. It was interesting because when I was watching the Olympics, and I wasn't aware of this, there's apparently significant, Southeast Asia, obviously the Olympics were in Korea. I didn't realize there were some pretty significant numbers in treatment in some of those Southeast Asian countries.
For gambling.
But for the electrical addiction, the gaming, we don't really see it that way in the States so much yet.
Bob, your comments about outside the world addiction. Orthopedic tendency to want to use, rods in people's bones and stuff like that.
We don't have that. We don't have that problem.
Orthopeditis, or what do we call it? I don't know.
We are, as a rule, the old style physician is oftentimes addicted, in a sense, to her or his job because it's so rewarding, and you can leave your family and go to the job and not be the family person that you need to be. And I thought I'd bring that up and ask for any comment.
I think there's some truth to that. I think you're right.
I'll challenge you with what I've always found kind of an interesting question of philosophy is does true altruism exist? Or do you always do something good because it makes you feel good? So
Yes.
in the end, is it ultimately that you are satisfying yourself?
You and my buddy Jack Ewing, who says nobody is a true Christian. You know, you do it because reward.
So as we drive down into that question.
So the psychiatrist.
I'm sorry. I should have laid off on you right there.
Well, we're talking about addiction and other issues, but there are other questions we've got. We said, how about opioids long term? There are some people, they're not accelerating their doses. They are using this, and they've been using it for 10 years. And their doctor's now more reluctant on prescribing the medicine that they've been able to. What does the physician and what does the patient have to do there, Bob?
I've seen some patients who fit that exactly, and they seem to get along okay. I just always want to warn them that you don't be taking benzodiazepines and start drinking along with your combination, because as your doses get high, the accidental overdose rate goes very high.
Right. And I looked at one study years ago, like 35 years ago, maybe more. And I was in med school when I read this. They looked at long-term VA patients. The patients that were the speed addicts commonly went on to commit suicide. The people who were the downers, the tranquilizers, the Valiums, the sleeping pills, they didn't have quite as much suicide as the people who were the speed addicts. The speed addicts got schizophrenic, flipped out. The addicts got severely depressed and also committed suicide in a large percent. The narcotic addicts just stayed where they were, did okay. But we're not seeing that right here in this country right now. They're dying. They're dying in big times because of suffocation. And I guess the answer, why is it now when it wasn't before?
Well, because I think the patient that Dr. Vandemark just described is not an addict, number one. And controlling dose, so there's another good VA study that indicates, the strength of your daily dose correlates to your risk of death. And that's why you see the CDC pushing down now the
Morphine equivalent.
Yeah,
dose.
it was around 90 used to be a risk marker, now it's down to 50. So a very clear correlation between how much you're taking and how much your risk of accidental or overdose occurs. But one of the things we're not really clearly differentiating in this discussion, or maybe in the national discussion, is those that are using the drug for a high and a feeling versus those that are using a drug to alleviate pain. And I think they're two very different populations.
Okay. Now let me ask you this. He talked about 50 morphine equivalent doses or 90 or 80. We were dealing with that in the Medicaid Pharmacy and Therapeutics Committee. What is the right dose which we should set in South Dakota on our Medicaid patients and so on and so forth? What is how much hydrocodone with Tylenol, the classic Vicodin? How much is that
I'd have to look up on my
per day?
CDC calculator.
Either one of you off the top of your head?
No, I
Is that
can't.
common dose?
It's like-
what's its morphine equivalent?
500,
I was going to say 10 or
Yeah,
10 tablets a day or something like that?
Well,
Or 10
10
500.
it's a 10-to-1 ratio.
Yeah.
Yeah. I think that's about right.
All right. So,
Carfentanil,
Yeah.
inverse proportion of
Yeah,
10,000 to 1. So
Carfentanil.
Yeah.
Traditional methods of treatment can be augmented by non-traditional programs.
We see still a lot of guys that are hooked on meth. Meth is devastating, of course, and it drives men to do like really foolish things, to say the least. It tears them apart physically, and it really brings them down fast. But we're seeing a lot of heroin addiction. An old drug that's kind of made a resurgence in the culture. A lot of prescription drug addiction issues, a lot of dysfunction and pain going on there. It might stem from an initial injury, and then these guys get hooked on these meds, or it can just be that whole subculture that deals with prescription drugs. So I have to encourage people often to let go and let their loved one fall on his face. And it's a very scary prospect, because these guys that are addicted, anything could go wrong. But it's not the parent's job. When the individual is of age and they rebel and they go against what they know deep down in their heart is right, then they have to deal with those consequences. So we have to tell families, back off, let them fail. Don't help them by enabling them to stay stuck. What we see are men coming into the program who are fearful, bitter, wounded, prideful. A lot of pride, you know, they may be messed up, but they want to argue, they want to self-defend and self-protect. So we see them coming in with all these hang-ups and all this, you know, shame and guilt and pain, but they're masking it, of course, with, you know, bravado and false pride and all this sort of thing. But when guys begin to humble themselves and begin to identify hope, and they begin to sense that, you know, God loves them, they begin to realize that they can be forgiven for their past sins and their mistakes and their failures. And when they know that you love them, then they change.
What a wonderful service that Mike Gilmartin and Teen Challenge provides
Because
for
you don't-
many people, and it's been very helpful for, I mean, success rate is higher really, but I think it's because it's a almost 16-month program.
Well, you just touched on a critical point, because it is the length of sobriety that really starts to change the percentage. The length of abstinence is probably a better term.
Yeah.
So the longer you're in treatment, the longer you're successful, the better your chances.
But do you know what I think has brought that program success? It's for men, right? So it's men who have found themselves in the world of addiction, oftentimes very young, and then through their early adult life until finally they just crashed and burned, and this is their chance to come up. But they didn't have, oftentimes, a male mentor teacher to say, this is the way we play the rules. Here's the rules. You don't do this. You know, you don't, you've got, your job is to take care of other people. You have a responsibility as a man. That sounds male-female unfair, but I think that there is a difference.
Well, let me conceptualize it like this. This is how I conceptualize it. The minute you start using a drug to try to make you feel better or avoid pain or move, that's where your emotional development and growth stops. And so one of the benefits of having a peer and mentor-based recovery is not just about abstinence, it's growing those areas that you stunted through your substance use, and you need mentors, and you need to reestablish what normal relationships and normal responses and normal emotions are.
Team playing, working together, learning to accept criticism. Any comments, Bob? Okay. So we had a question about South Dakota State Medical Association website. So you had mentioned it earlier.
Right, and there's a hyperlink on the website, and I think we have maybe a graphic we can show. But anyway, it's for about drug abuse, and you can go, and there's material for both providers and for patients. And it's a nice little thing showing, even which I think is a nice thing, is showing the addiction services available with names and phone numbers.
Wow.
So if somebody has a problem, they can call and
Place to go.
get going. Yes.
So one of the things that in my lifetime I found that guys would come in to see me because their wives dragged them in, or the other way around sometimes. But that it is the care provider in the family that brought the person in that was in trouble. So is it fair or ethical for a wife or a husband who sees a problem in their spouse or their parent or their child to call for help and to try to get them help, intervention?
Yeah, I would say absolutely, and here's another truism I would say. perhaps never, but if so, rarely, ever seen a patient come to treatment for an addiction without a consequence driving them. So typically, it is exactly what you just described. My family is
Can't
fed
take it
up.
anymore.
My wife says she's done. Or it's a legal problem. Rarely is it a health problem. People will drink themselves to death. It's typically the other, I'm gonna lose a relationship, I'm gonna lose my freedom, I'm gonna lose my job and income. Last of all, almost, is I'm gonna lose my health. But there's almost always a consequence driving it, and that's what interventions do. They reinforce, they push that consequence. Our family is being damaged, we're hurt, you need to make yourself well.
Right. I've heard some people say that I've pushed him to rehabilitation, I've pushed him to another rehabilitation program, we've paid up the yin-yang, the third rehabilitation program, we're done, out. And then they finally have to reach the gutter.
Yeah, so let me make a distinction. A consequence drives them, but you can't, and this is one of the mistakes I made early in my career, no one can heal that person but themselves. So it ultimately comes down to
Them.
how much does that consequence motivate their effort?
And if you soften the consequences, oh honey, I forgive you for being an alcoholic, or addiction on the opioid, or whatever it might be, the addiction, or maybe even the abuse. I forgive you, it's okay. How many, do you soften the consequence that prolongs the suffering and the misery that person's in?
Ultimately, absolutely, and ultimately, though, that external drive has to become an internal drive, but that doesn't happen easily or quickly for most.
We have a question: why are heroin users and overdoses lumped with legal use of prescribed opioids, Bob?
Well, they're really not, I guess. There's a differentiation between the prescription opioids and the fentanyl and heroin.
But the prescription opioids may be stolen or diverted or purchased illegally.
Right.
Well, and if you look at the way the CDC reports those, they do talk about opioids in mass, but then they break them down, as Dr. Vandemark was saying, into the different subcategories. And actually, as you said, percentage-wise, the prescriptions are actually at one of the lower contributors, still very significant.
If a patient had success, I love these are questions from people who are watching our show right now, even though our show is not live.
Just shows you have an intelligent viewership.
Yes, we do. If a patient had success with medical marijuana, where it was legal, but now lives in South Dakota where it isn't, how would you treat their pain? Now, let's talk about marijuana as a pain reliever. Any comment, Bob?
I don't think the jury's in yet on how well that works, at least from the scientific basis.
I would agree,
Yeah.
but I'll add a couple anecdotal comments. I have a good friend who's a PM&R doc, or
What's that?
physical medicine and rehab. So they deal a lot with pain, chronic pain, sometimes post-orthopedic pain, or at any rate, he was actually getting his re-education. We have to go through maintenance of certification. We have to continue to train ourselves. He was with some friends, former resident trainees with him in Colorado, doing an education piece. Talked to them about their practice. One of the most interesting things they said was, the medical marijuana has actually been a good thing for us. Not necessarily endorsing the idea that marijuana is a powerful pain reliever. I think that is still out there. But what they said is, we don't, to answer this person's question, we do not prescribe both an opioid and marijuana. And in fact, most people who prescribe opioids for chronic pain require drug tests so that they know what else you're taking with it. And Dr. Vandemark mentioned the other really powerful tool is that PDMP, Prescription Drug Monitoring Program. But what they said was, when we tell them we can't prescribe this if you have marijuana in your system, they choose the marijuana over the opioid. So that tells me there is something there
that helps with,
for many. I'm sure that's not an all or none. It's not everybody in one camp or the other.
Yeah.
But
I have more than one anecdotal case of a patient in severe pain got off the narcotics using marijuana, and then could easily get off of the marijuana, but it was hard to get off the narcotics. I mean, you know, I've heard that and heard that, and I think there's some data on
I
that.
will say though, in this state though,
It's not legal in this state.
and inevitably, you are going to run into physicians who are doing drug monitoring are going to say you can't do that if I'm going to prescribe opioids.
Yep. There's a pleasure center in the brain. Bob, talk about the endorphin system and where, you know, and where maybe we'll get something from Matt too, but
Matt might be a better person to talk about.
Could you quickly draw the basal ganglia for us on the table?
Piece of paper, please.
okay. Well, there is a pleasure
Nice
center.
question.
Good question, he said. So my point is that they have called it endorphin, that there is a receptor that receives the morphine or the opioid that gets the relief. But then, of course, it gets, it becomes, you have to have a higher dose to get the same relief, higher dose, tachyphylaxis that you alluded to earlier. And my point is that those systems are natural. I mean, and we can turn on our own endorphin system without morphine. But that's the pleasure center, right?
Yeah, well, and if I had to point to a neurotransmitter, almost all addictions point back to dopamine. And dopamine, if you look at what that neurotransmitter does in our system, it is pleasure, you know, it is a powerful neurotransmitter. But let me give you just one statistic. It comes from a NIDA study. So if we take a basal rate of 100 for normal dopamine production, when a rat eats food, that pops up to 150. Probably why we describe things as comfort food. We
Yes.
actually do feel better. Sex between rats jumps that rat from 100 to 200.
Oh.
You probably only get to about 180. But anyway, but if we take methamphetamine, that jumps from 100 to 1,000, 10 times.
From when you get what?
From methamphetamine. So it is 5 times as powerful as the effect of like sex or food, which are naturally built into us to reinforce behavior.
Powerful.
So they are powerful drugs, and then we haven't even talked about the genetic differences in us, dopamine transmitters, receptors, how each of us individually, the soup in our brain, how it responds differently.
And we're running out of time. But I want to make one comment about endorphins. You know, you can give placebo, get 70% relief. You give narcotic, it's 80% relief, and then you reverse it with a narcotic reverser. Mm-hmm. It's amazing. You can reverse belief that you got narcotic with the narcotic reverser. And now for the answers for tonight's Prairie Doc quiz question. How many people died in the U.S. in 2017 of car crashes? About 35,000. About from alcohol abuse? Near 35,000. From suffocation from opioids, Bob said earlier, 64,000. We'll be right back after this.
Because you don't want to miss out on the little things. Because you want to be there for life's important milestones. There are many reasons to get life-saving cancer screenings. More than 4,000 women die each year from cervical cancer. But regular screenings can prevent this cancer and catch it early. Do it for the people you love.
Promise?
Promise.
Promise.
Promise. Promise.
Make the promise to get screened. For more information about life-saving screenings or available financial assistance, visit getscreenedsd.org.
Years ago, in another state, a physician friend became addicted to opioids, also known as narcotics. She was one of the smartest doctors I knew, ethically based, raised in a loving family, had children and a spouse. I think it started with a sports injury and pain medicine. Eventually, she was divorced, which likely had something to do with her addiction. She said the opioid had a hold on her, and she just couldn't stop. Years later, she told me that it wasn't difficult to acquire the prescription medicines, but somebody must have been watching because she was caught after about 3 years with an accelerating need for higher doses. My own experience with opioid pain medicines after pancreatic cancer surgery in May of 2017 was colored by my having observed my friend's struggle. Physicians are a high-risk group, and addiction to narcotics was not something I would accept for myself. Despite that determination, the pain was bad, lasted for 3 or 4 months, and required those darn pain medicines for a prolonged period of time. 2 months after the surgery, still needing pain medicines, I better understood how people could get addicted to narcotics. In retrospect, I know that at least some of the discomfort I was experiencing had to be secondary to withdrawal from the pain medicine itself. One definition of addiction calls it a condition resulting when a person ingests a substance like oxycodone or alcohol or nicotine, or engages in an activity like gambling or shoplifting or internet gaming that might seem pleasurable, but the continuation of which becomes compulsive and interferes with ordinary responsibilities such as work, relationships, or health. Experts tell us addiction isn't always due to a physical dependency, a search for pleasure, or a flaw in moral character. Rather, it is often a reaction to escape stress. Methods to help people find release from addictive and compulsive behaviors are myriad, but the most successful seem to be faith-based, associated with counseling and emotional support, and provided over a prolonged period of time, like 16 months or more. For me, getting off opioid pain medicines was accomplished by gradually tapering off the stuff while increasing exercise, performing creative activities, finding interests outside myself, while opening my heart to spiritual sustenance. Also important for me was the support and companionship of my wife. I learned that surviving with comfort and escaping the compulsion and destruction of opioid addiction can be done, but requires doing the work as well as making the choice to get and receive help. A big thank you to our guests and friends, Dr. Bob Vandemark and Matt Stanley, for volunteering to come to our studio at Yeager Media Center on the campus of South Dakota State University. Their experience brought a lot to tonight's discussion. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions. Brookings Health Systems, Ophthalmology Limited, American Academy of Family Physicians Foundation, and South Dakota Academy of Family Physicians. Avera Heart Hospital, Dakota Allergy and Asthma, CoBank, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen District Medical Society, Black Hills Medical Society, 3rd District Medical Society of Brookings, Madison, and Flandreau, Dakota Bank, Orthopedic Institute, Physicians Care, Sanford Clinic Community Service Committee, and Swiftel Communications.